Hello and welcome to this month's Fire Chief's video message. It's February 2023. We're back in the studio here at the EOB on the 4th floor. Actually, it's our second time back in the studio for Ben and I. Welcome to join me, Ben.
Thanks for having me.
And as Ben said, take two. We came back last month. We had some challenges in how we were able to get the video together. So that was our dry run. This is a take two. We'll be, top performers in this activity today. So, you and Dr. Chismar, as well as Megan Harrell, had challenges in the street events back in November, and there was some information that you and I talked about afterwards. Other stuff that we wanted to continue to share information about that you didn't get a chance to in that video. So, asked you to join me, and here we are. So. We're going to cover a lot of topics today and look to share information. As we rolled through the Christmas and holiday time frame back in December, it was busy. The hospitals were getting busy, and there was an announcement that came out in the news that caused some alarm to the community. That was pretty important. What is that?
So we did see a surge of patients going to the hospitals right after Christmas. So from a couple days after Christmas through the first couple weeks of January, there was a huge surge. All of the hospitals in our region were full. Caused the statewide, the agency that looks at hospitals called MHA, Maryland Hospital Administration, issued a press release. This was, I think, on January 6th, advising people to only go to the hospital really for serious and life-threatening emergencies, and to try to find or seek medical care in other ways unless it was a life-threatening
primary
emergency.
care, urgent care, not the hospitals unless it was life-threatening.
Exactly. So it got to the point that the state actually had to intervene on behalf of the hospitals themselves.
And we've talked about, and it's well known that Maryland is in the lowest of the categories for the highest ER wait times, and that was touched base, when you were back at the academy a couple months back. This goes into the amount of patients we're seeing, and that's a lot of activity. We're running 95,000 EMS incidents last calendar year, so that's a little bit about 7 to 9% uptick. And that is going to be, equating to, 73, 74,000 transports. So what do you got here?
If you think back to where we were about a year ago, we were in a COVID surge at Omicron.
Mm-hmm.
We're coming out of that, and if you look what happened all through calendar year 22, we had this steady increase in the number of patients we were running week over week, to the point that by the end of the calendar year 22, just last month or so, we were seeing more patients than we'd seen all through COVID, and we're back to pre-pandemic levels. People like to talk about where we were pre-pandemic.
Exactly.
That's where we are now. In fact, we even got above that through the end of December and January.
Yep, and there was a couple incidences where we had our EMS surges, and we hit those triggers. And let's talk about what that is and where those steps are.
So this goes back a while. My Chief Bush, Chief Kinsley, they had thought through what an EMS surge might look like. Coincidentally, they kind of tied it to what a future pandemic might cause through the healthcare system and EMS. We actually saw fewer patients seeking medical care for anything but COVID, really, through the COVID surge.
Fewer but sicker, but
Sure.
people were afraid of calling or going to the hospitals, but they were definitely sick.
An offshoot of those, of the planning for a surge, was to alert us to decrease in availability of EMS units. So we have trigger alerts set up for a certain number of units available or unavailable because they're on a call. And that's based on the percentage of transport units that we have at any given time. So we think a round number of 42 or so, 43, depending day or night. And when we regularly get to 25. From time to time we get to 30, but we had never gotten to 36 units being on calls. And on January 4th we hit that trigger, and those of us who had received it were texting one another and saw this like, wow, this is really a big deal. So we actually had 36 ambulances on call.
Right, and that was the thing when you talk, that there's sometimes it could be a brief incident, a single, large incident that's making a demand. Let's just say an MCI, that you tag 10 EMS transport units, and otherwise things are quiet. As this slide talks about, talk about that hospital throughput problem. We started off with the issue, right after the first of the year, but that's another example, right?
I think the thinking was if we ever run into problems, it's going to be because the hospitals cannot physically move patients and our ambulances are going to be tied up for 2+ hours. The surges that we saw at the beginning of the year, specifically January 4th, was not a hospital throughput problem. Right. This was a temporary, widespread demand problem in the county. People called 911 continuously asking for EMS care over the course of a couple of hours. And it wasn't one spike. It spiked and then it stayed there at a high level for an extended period.
Right, and there's a lot of different things in the plan at the 30 mark, at the 25 mark, and then that engages resource availability. Units on a detail. The duty chiefs and Chief Bailey have a very scripted process of things to look at in conjunction with the EMS section leadership. And we have we call them the B units, but the B or C units that are in station, we have a means, and part of that plan hits outreach to the LFRD personnel to see what resources could be added in that surge, clearing any resource, any cot that's all a detail or not available for running. The reality, when we know, like you said, 42, 43, some of those cots are probably available, but they're geographically remote and limited, and they're just really not practical to move that cot to a more part of the core of the county. And then at times the need to support the service and the residents and the women of the department is to adjust, and add staffing to those B units so that we can address that surge. So seeing it, like you said, a couple times a day, almost every day we hit 25. Occasionally, once or twice a week, we're hitting that 30 mark, but there's a lot of effort done by both the EMS DOs that are out there, the EMS section folks, as well as the duty chief and the ECC staff, keeping this watchful eye.
Yeah, so the bottom line is we have to take action. When we get to the point that we're running low on resources, we have to take some action. And all the actions that are varied. There's probably 10 or 15 different things that happen when we get to these high trigger levels. They're all to increase our unit availability. So We're doing things like adding the extra transport units to increase our capacity, but we're also directly at the hospitals asking the hospitals to increase our turnover or decrease our wait times, right?
Yep.
Let's get the people off of the stretchers, turn ambulances over, and get back to the community, be able to respond to calls. Right?
Yep. And that segues pretty well into one of the roles at EMS 700 is functioning as, and he or she has a multi-pronged approach to how they provide information to the member who's calling on 7 Alpha 13.
Right. So when we started EMS 700, it was an offshoot or one of the many things we did to prepare for the COVID surge that we anticipated. And it was to make sure that no individual hospital got overloaded by telling our transport units, this is the best hospital for you right now based on capabilities and how many transport units are there, et cetera. Through those EMS 700 activations through COVID, we learned that job was much more than just telling ambulances where to go, and we had opportunities to improve the clinical decisions that were made on any given call and really make course corrections during the call rather than having problems after the fact. Mm-hmm. So we're seeing that continue now, that it's not just about transport disposition, it's really clinical oversight for every single patient interaction in real time.
Right, and there's a lot of tools out there that everybody can use via the Sonim devices on the apparatus by the cell phone to see the hospital wait times, to see how many units are in a queue, hospital, the chat status, and on their phone. yes, EMS 700 is helping in part of that arena, but there's these other elements that they do provide. And one of them, as we want to focus on and we've been talking about, is the downgrade confirmation.
Sure. So you'll hear EMS 700 talk about, they get dispatched on an ALS-1 call and a BLS unit calls to talk about transport. EMS 700 will say, is this an ALS upgrade? And if not, was the downgrade process followed? So that's one of the things that they're doing in coordination with that unit calling, looking for a transport disposition.
And that's a multi-part process.
Right.
It's not just done by the ALS provider, it's the ALS provider and the BLS provider, as well as the unit officer if you have a primary unit there.
Sure.
So
this is a whole way of thinking for the department. And can I speak openly for a moment?
Sure.
Okay, great. Those of us who've been around as long as I have rode two medic units, and when the system switched to single medic units and then ambulances with primarily moving to AFRA delivery model for ALS, there wasn't any guidance really established by the organization to talk about what the downgrade process looked like. It's pretty evident that the system wouldn't exist effectively if the medic had to upgrade every single time. The purpose of dissociating the medic from the cot was to increase ALS unit availability and make sure that a patient that didn't require ALS wasn't tying up the medic. Mm-hmm. So we put the system in place but didn't have any framework for how the system was supposed to behave within that delivery model. So the downgrade process comes in after the fact, far overdue, to explain to the organization, this is the framework, these are the operational guidance or operational guidelines for how we deliver care when the medic is not going to be going to the hospital.
Right. The guardrails that ensure that we're aiming to provide the best care for the patient, as well as ensuring that the providers are all aware of and supporting the action plan as the BLS crew that's engaging with that transport needs to be aware of and ensure that they're comfortable with the patient they're obtaining.
Everybody does. This is, yes, it comes from the medicine, but this is an operational guideline. The same way when you're having an operation, there's a surgical timeout, and everybody that's in the room, not just the surgeon, but every person that's in the room understands this is what we're here for, this is why we're doing what we're doing with purpose. Right. And this comes from, again, the department putting the cart before the horse and having these experiences of bad clinical outcomes from not having a process, right? We, in effect, amputated the wrong leg for many times until we got this framework in place.
So, and that's exactly part of the reason why you're doing outreach and education, and we're talking about that, and we put that out in the 5-minute drill. We put additional information out pertaining to the downgrade checklist, and why we're touching on it here is just to ensure people are aware of and get back and refer to that and every time.
Yeah, and it's not about anything other than patient safety and protecting the organization and protecting individual clinicians of acting within a framework. Otherwise, we're not. And this is not just about documentation either. This really is about the process of having a timeout, working through the checklist and saying this patient meets the criteria.
Right. And we're going to touch documentation in a moment.
Yeah.
But one of the things that 700 does for us as they do that balancing act of saying no, somebody in the Briggs-Cheney corridor, it would be best for you to take your patient across the ICC to Shady Grove, is to aim for reduction in drop times, reduction in wall time. So, what have you seen since October?
So I have a couple of graphs here that show that our median drop time and then our 90th percentile for drop time, which is, to define this is the time the ambulance arrives at the hospital until they're clear and available for another call. This drops significantly, and you can see that beginning on October 1st. So we started this on October 9th. And then we have these really nice low periods through November, December, and January since EMS 700 has been in place. But what we really care about is cycle time. So that is the entire time from the dispatch
to in-service. Yep.
Dispatch to in-service time. and we can see that the drop time is in fact translating all the way through to cycle time. And what this means is that our EMS units are not tied up for as long on a call. We've increased our unit availability and service to the community. And this is, while maybe not directly a cause, EMS 700 may not be directly causing that, it's certainly correlated to that. There's been some other things that have put in place at around the same time to increase our unit availability.
And we would always have said in the years past, a traditional, and what is a traditional EMS call, but the average EMS call is roughly 70 minutes, from beginning to end, and that's what the cycle time, shows you. But as you see that's making the adjustment, and when you really get to the volume and the capacity of those calls, as we can adjust and reduce, almost 20 minutes on the cycle time of calls, that is critical for the crews involved, the patients involved, and the system's elasticity to be able to address, because the volume of calls is there.
Not only that, but even 1 or 2 minutes, because of our volume, even 1 and 2 minutes drop of a cycle time within a week or a month's time is really huge. That's a huge benefit. I want to touch on one other thing about EMS 700 before we move on. With the clinical oversight, we're now 2 months in a row, now that through all of December and all of January, we've had no stroke patients taken to a hospital that was not the wrong hospital. So we ask for the LAMS score when a patient is having a stroke, and if that LAMS is high, meaning an LVO, large vessel stroke, those patients have to go to either Shady Grove Suburban or a comprehensive stroke center. For many months, we were having a few of those happen. With EMS 700 oversight, we've had every patient taken to the right hospital. So,
good work by everybody out there, because time is critical, as well as the right receiving facility.
Yeah.
We tagged a moment ago about documentation, and that was really one of the things that you got into in November, was the discussion about the operational support report and how that works. Get back on that topic and tell us about that.
So we're in conflict here between what COMAR, state law, says that we have to write an EMED report every single time the ambulance runs a call. We're in conflict there between our RMS policy, which requires an EMS report anytime we have a patient or a refusal. So what that has done here locally is leave this huge gap of calls that we're running, that there's this gray area where it wasn't a patient and it wasn't a refusal, but we're missing opportunities to document appropriately. So in the meantime, while we're updating the RMS policy, the purpose of having EMS 700 be contacted every single time we have an interaction with somebody was to make sure that not only was the clinical care right, but also that we are able to direct the documentation, which is not going to be something that people are used to doing. And that's this operational support report for things like it was a second party caller, but the person doesn't want any help. It was what was intended to be somebody who fell, but it really just ended up being a lift assist, these type of things. So we are working towards having the organization write EMEDS reports on all of these calls, and in real time we're asking EMS 700 to tell people you need to write an operational support report.
Right. And you got a video here that's going to play. Talk to us about that video.
Sure. So this is really just showing how simple it is to work through the steps of operational support. Again, these are the calls that are a lift assist, not a patient necessarily, but somebody that we did an assessment for. We'd have no feeling clinically that the person needs to go to the hospital, but we do want to make sure that we document that happens. So this is showing how with limited validation rules, you really don't need a lot of fields filled in, and it goes relatively quickly.
So we're going to play that video here, and then we'll come back in a second.
Great. This is an operational support report. So the role at the end of the incident is non-transport other reason. The disposition is operational support, no patient contact. Where it says patient, we do still want to enter basic information. And get an address here. So this is whoever we interfaced with, whether it was a lift assist or whatever. You have to add a narrative and then the signature of whoever is completing the report. and we are done.
So I hope everybody has a chance to watch that, rewatch that, go back and find that, use that as a tool. That's also independently posted on Quick Links, right, Ben?
Yeah, it will be, yes.
So as we tape this today, we know that in a couple of days this will be released. So by the time this is released, this video will be independently available on Quick Links.
Very well.
Exactly. So the beginning of the year changed also some stuff in our ET3 arena. We've ended our telemedicine engagement, and some things are changing on alternative destinations, right?
Yep. So for those of you who don't know, ET3 was kind of the umbrella term for the efforts we were making to provide patient care outside of what we typically do. So taking people to the hospital is what we normally do. We added in our alternative destination transports and telehealth. Well, our contract ended with the physicians group who was providing telehealth, so that service is no longer available to us, but our alternative destinations are still very much available. All this training is available on EMS Quick Links to talk about the patient eligibility. It's in Maryland protocol. So we have Kaiser that's available 24/7. There's 5 MedStar urgent cares around the county that are open during the day. And then we have the Casey House, which we've partnered with to receive Montgomery Hospice enrolled DNRB patients rather than taking them to the emergency department when they, oftentimes out of desperation, call 911 or their families call. We can get them over to the Casey House in coordination with the Casey House.
Correct. So as we work with the health industry, we're seeking how to continue expanding, re-engage on some of the alternative stuff. Here on the slide, there's some future things that are in the works. One of the things about change is it takes a while to make some of this occur, and especially since these are brick and mortar structures. What do we have on the future with the Crisis Center this year?
We're finalizing an agreement with the Crisis Center. They have a handful of recliners, so we're thinking that they would be able to receive a nonviolent, like maybe somebody who's called 911 or entered our system for depression, anxiety, something not suicidal intention, anything like that, but they're really low acuity stuff to avoid the emergency department visit and really keep those beds available for more sick patients.
Right, and that's going to lead to a very energetic work that's ongoing across county government and nonprofits as well as the health organizations of a stabilization center. Sure. Describe stabilization center.
So this comes very necessary that we need more behavioral health beds in not only the Montgomery County but across the state. We have a need for behavioral health care that is really those patients are driven to the emergency room right now, and it takes up resources there, and the emergency departments are not correctly resourced to care for these people. So the stabilization center will be a no wrong door place where people can walk in, the police can take people there, we can take people there, and they'll have medical staff and psychiatric services for really having being the best place for these type of patients, and also keeping our emergency departments available for other kinds of things.
And there's a lot of work going on. A area of interest is in the 7 Locks Road, where the old 1st District Police Station is, where there's a lot of community engagement there. That's going to develop. Building is going to be purposely built in that place or potentially purposely modified to support the stabilization center. So good work on the horizon, and the team includes Avital and several others that are working collaboratively week after week with the HHS and the county team to move that forward. So things on the horizon. Segue from the future to segue to the current and the past. So right at the end of the year, one of the messages that was distributed by the command staff, one of the messages that was pushed out there was talking about EMS PPE, talking about what is the core and basic. And on the video here before, in stations visits, at the beginning of the pandemic per se, people said, well, when are we going to get rid of the face covers and on calls. And I said, look, never. The reality is gloves came in the 80s, and we would never think twice about having patient contact today without having gloves. The surgical mask for low acuity N95s for high risk circumstances came with the pandemic. It's not going away. It's definitely the appropriate level of respiratory, and personal protection to the provider as well as the patient for all patient contacts. So the face cover surgical mask / N95 is not going to go away. And we articulated as part of the pandemic the eye protection, and that's where we're really seeing, and we want to touch here again, the function that eye protection is needed on all patient encounters.
Sure. So just like the gloves came out of the 80s and 90s, we would, those of us much older than us would remember a time where they weren't wearing gloves. We will also remember a time where we weren't wearing face masks and eye protection. But it is the standard now. We have to be walking into every patient encounter with a face mask on and eye protection. And there are times where if you're not directly involved with patient care, you can put the eye protection up here on your head. But if you're right there with the patient, you have to have your eye pro on. We're healthcare practitioners. We are clinicians, and we're involved with patient care. We have to protect ourselves and protect our patients. We had a couple of exposures recently where people got blood and mucus in their eyes, and they weren't wearing eye protection. So
Yep.
it's going to take some time for people to catch on. But we've already been doing this a couple years, and I tell the EMS supervisors they're not the PPE police. This is personal responsibility and it's policy. So I just,
Yeah. And it's a question of, and an importance of, have that protection on. Just like we articulate the need for, gloves when you're operating, saws, and eye protection when you're operating saws. It's just a transition over. How many times have you operated a chainsaw at home without gloves or without eye protection? And then have that one time that, something does fly and move. Just like how many patient encounters have you had without eye protection in the past. Sure. and then have that. But it is core and critical, and it's part of the EMS PPE plan. And anything else on EMS PPE before we hit cot straps?
Cot straps. So having a conversation with the safety officer just through observation, some of the EMS supervisors reporting that we've kind of laxed on this general order that requires 5-point patient restraint. While I have the opportunity to sit with you, I figured I'd throw that in there, that we do have a general order that requires cot straps. So put it on everybody to make sure they're in place and actually used, especially with somebody who is sitting bolt upright, and then when that cot is in the high position, you're really top heavy. We've had patient drops, and they're sometimes catastrophic, and we don't want that to happen.
Absolutely, and that's the thing is, EMS logistics, technically, and small tools, they're always available, and we'll make sure that cot has all of its restraints. Secondly, the fact is the upper body and the torso with only one strap across the chest, mid-chest area. When that cot has a overturning event, the pumpkin or the head is going to come outside of the cot's frame, or outside of the confines of the cot's side areas, and that's where that over the shoulders engages the heavy part of the body and keeps it on the cot, and then thus engages the head to stay within that cot area. And it's important. Sometimes it may be medically contraindicated, and absolutely we do what's necessary and right for the patient care. Vast majority of the times that's not the issue, and we need that cot, the shoulder straps on, and that patient properly safe to the cot. Yeah. And safe to the cot, as we've talked about, is not fully elevated, with the only exception of while entering and exiting, the back of the EMS unit.
Yep, cot all the way up is for loading and unloading.
Unloading only. It's always best, and it's in the instructions to be, at that about 60% or so level any other time.
Certainly.
And always roll in the direction of the cot, as opposed to, cross the grain, as the cot is very unstable when it's rolled sideways.
Yeah, and these are common sense things too. You're on a hill, you're at any unstable road
Yep.
or
surface.
Yeah, you lower it. The lower the better at that point, right?
Yep. So the news today, and as we tape this in February, we are really seeing in the community, and we've been engaged, and I thanks to all the folks who have assisted us and assisted the community recently with some media information about Narcan. Leave Behind Narcan is on the rise, as well as something that's really become a current trending topic.
Sure. So this is coming from the opioid crisis that we're in. There's nothing particularly new about the volume of cases that we're running, but I think it's got some media attention recently because some of these cases are they're children, they're happening in schools, and they're kind of clustered in a way that we believe there might be some bad stuff going on in the community. So the Leave Behind Narcan program has been in place in the county for a while. It used to be that you had to call a duty officer out to drop off a kit and do the documentation. Well, that switched up when we had an influx of availability of the Leave Behind kits through HHS. Those kits are on every primary unit and in the station. You do not have to be tied to an incident in order to give out one of these kits. Anybody can stop by a firehouse and pick up a kit. We can give them out in the community. However that's done, we just ask that you document the distribution of the kit so that the HHS people can track it and our MIH folks can track that these kits are given out.
Yep, and it's going to continue to be a problem as you said, the opiate issues are on the rise. Montgomery County Police has been very engaged. You will see them come to any overdose event, any activity. They're going to do a huge amount of follow-up on those cases, indifferent to the age of the patient, and trying to determine what and how that substance was obtained. The most important thing, as we know, is providing the Narcan, naloxone, to that suppressed LOC with suppressed respirations, obviously having no harm if it's not a opiate issue, but it's part of one of our tools and our algorithm of treatment based upon patient conditions. So,
sure. So it's more. This push is obviously for the public to have Narcan on hand in the case of they're a bystander to an opiate overdose or suspected opiate overdose, and their protocols. They don't have protocols, right? They can certainly use it whenever they suspect it, and that's separate from how we administer Narcan for sure.
Yep. So this is another segue, another follow-up. We've had some information shared with the field. You and the folks, I use the phrase upstairs on the third floor at headquarters in the police department, have had a lot of coordination as things at the state level have changed. Things have gone through the police and law enforcement agencies, and we've had some interactions, and we needed to collaborate and then coordinate. So what do we got here with our police interactions?
Sure. So this is a screenshot of a 5-minute drill that went out last year about how we work with the police, specifically the transport of patients who were in police custody. Some observations we're seeing recently are emergency petition patients, which is a police process. The person is in custody of the police at that point, are being transported by us without police attending to the person in the back of the ambulance. There's this spoken or unspoken thing that happens on the scene where the police meet us at the hospital rather than stay with the person who's in custody, and that obviously cannot happen. So we're trying to head these off again at EMS 700 through those radio transmissions, but just a reminder to everybody, if you have somebody who is in custody, whether it's an EAP or otherwise, that a police officer must attend with that person in the back of the ambulance. One of the biggest things here is when the police call us to assist with somebody who's agitated, that we have to stop and really approach this as a medical case and not get caught up in anything that the police might be doing with respect to law enforcement.
Right.
And sometimes the police will call us and want a reef stretcher to help restrain a bad guy, right? And we're not in that business at all. It's hands off for us in terms of police issues. If we get called to assist somebody who is having a medical issue, absolutely engage, but conduct an independent medical assessment and treat accordingly. If it's an agitated person, remember that agitation is assessed on a scale. mild, moderate, and severe, and in some cases require medication management of those agitation cases, but that is done independent from what the police might be doing.
Correct. And if you see that POL assist call, the information is being garnered from dispatcher to dispatcher on the radio, and by far we want the EMS crews to treat the patient after a complete assessment and determine what needs of resources are appropriate for the patient. Request the ALS resource. It's very likely that the field supervisor on the police side is going to ask for the ALS because they know and they're attuned to what resource they need to ask for. So treat the patient after the assessment.
Yeah, and you also start seeing an EMS duty officer dispatched on those agitation calls. We really want a high level of coordination and oversight of these calls. They're very dynamic, they're chaotic in some cases, and we want to make sure that we're absolutely doing the right thing medically. The supervisors on the EMS side are really in tune to these issues and these type of cases. And one other point on these that maybe an area of conflict that we're working to resolve is if a patient is restrained and they're in police custody and they're in handcuffs, the handcuffs absolutely cannot be behind the back. This is something we have to correct, and we cannot transport somebody. So think about if the person is handcuffed behind their back and they suddenly become unconscious or need medical care, we're not in a position to access their arms, and it makes it difficult to do that. So in the front or restrained to the rails of the cot, high and low.
Yep, right. Absolutely. And that's what this 5-minute drill talks about, and those key points to remember. And it's everybody's job to highlight that and realize you can't do certain things, and here's the certain things we must do. So a lot of coordination, continually refining that coordination on interactions between county police, sheriffs, as well as the city police and the fire department.
I'll just close by saying that everybody is doing an amazing job out there. There's a tremendous amount to keep up with. Things are constantly changing at a pace that I can't recall. Not only clinically, but how we're performing operationally, and it's really tough out there, and everybody's doing a fantastic job.
Absolutely, and that's exactly what we always highlight on one of the videos. On the video is great work done by the crews. Just a week and a half ago, we had a very tragic incident, double fatality house fire in 21's area on Oriental Street, and that demonstrated amazing work, both with the coordinated attack and suppression activities, as well as a ROSC on one of the patients, cyno kits being provided, both being transported to MedStar, but amazing work done by everybody on that call. That's just an example of the amazing work done every day.
So I happened to be the EMS group supervisor on that call and watched the transition as these victims came out of the house fire in cardiac arrest, and saw immediately people move from firefighting to EMS care. As soon as the people hit the ground, they had chest compressions done, and that just speaks. It's a testament to the mindset that people have for really providing excellent medical care.
Yep, and I know Chief Filani's worked on engaging communications with his folks after that event, and great work by everybody there on Oriental Street that late night, early morning. But again, it's just another example of the great work that's done, 300-400 times a day across the county. Yep. So anything else to add?
Appreciate your time. Thanks for having me.
No worries. Yeah. So while I used the word it's February, it's almost 60 degrees later this week. I think we've had a little bit of winter precipitation here. Definitely could still be ready for that, and hopefully we don't. Hopefully the groundhog was wrong, and we don't have any winter, and we'd be aiming to spring here real soon. Lots going on in the department, in the community. So reach out if you have questions. Grab the video. Till next time, stay safe.